very clear, especially awakening us of all the landmark trial of antiplatelets in ACS and in post-PCI patient. And I'm sure that we will have very lengthening discussion of this because we still have more than 30 minutes. But first, I would like to ask Dr. Bambang to guide the discussion on Dr. Doni's presentation, and maybe we can have Professor Gabriel Steck's opinion on how the SCS in COVID area of COVID era in Paris. Please, Bambang.
Okay, thank you, Dr. Sunaria. So actually, I have some questions for Dr. Doni as well as for Prof. Steck. I think for Dr. Doni, you know, as in pandemic era, any ACS patient should be considered potentially infected. So let's say if we have clinically stable non-STEMI patient and treated medically, what is the safer strategy in avoiding of spreading infection? Is PCR a must before sending the patient to the cath lab for early intervention? And for Professor Steck, you did not mention about the high bleeding risk patient with atrial fibrillation who need triple antithrombotic therapy. Do you have any recommendation regarding P2Y12 inhibitor of choice or NOAC of choice, especially for Asian population who have special or specific characteristic in terms of high bleeding risk? In dual PCR trial that you are involved, combining that with dabigatran, the percentage of ticagrelor is pretty low, it's about 12%, and showing higher bleeding rate, higher bleeding complication, I mean. Do you have any comment regarding this issue? And then the second question is, do you think personalized antiplatelet therapy after PCI by checking platelet reactivity, especially in complex cases, remain important issue to avoid bleeding as well as ischemic complication? Because not only the issue about low antiplatelet responders, but also high responders also make our serious problem. Thank you.
So I'm going to first take the question. So I think regarding the non-STEMI, Dr. Bambang. So of course, if you deal with the very high risk non-STEMI with the cardiogenic shock, with prolonged pain or malignant arrhythmia, so you should take the patient to the cath lab as soon as possible. So if you have no isolated cath lab or dedicated cath lab for COVID, you should refer the patient to the hospital, the nearest hospital who has a dedicated cath lab. But what about for intermediate risk of a non-STEMI? So I think it depends. So how ready your hospital is. In my hospital, initially we tend to take to postpone the invasive strategy as long as possible. But right now, since we already have a PCR test in our own hospital, so we can make it do the PCI for the patient maybe in let's say 48 hours. So it's really depend on how ready your hospital is. Because it cannot be applied to all over Indonesia. I really understand that, but I think that is my answer, Dr. Bambang. Thank you.
Okay, thank you, Dr. Don.
Professor Steck, I really want your comment because there are questions from participants on the effect of Avigan, whether is there any issue that COVID patient given Avigan can stimulate for STEMI event. Is there any report of that?
What is Avigan?
Avigan is remdesivir.
Oh, remdesivir.
Okay.
Oh, so I have no idea.
No idea.
I absolutely have no idea about the effect of remdesivir on this. I'm happy to discuss the issue of oral anticoagulants and triple therapy. It's a very important issue, and it's a very complicated issue, as we all know. I could spend 40 minutes reviewing the evidence. I will try to make it simple. Number one, as we often discuss with my Asian colleagues and East Asian colleagues, clearly among Asian patients, there is, number one, a particular concern regarding bleeding. And there seems to be some additional susceptibility compared to Caucasians in bleeding. So that, as you all know, there is a trend for using slightly less potent or reduced doses antithrombotics in Asia compared to Europe or North America. Number two, when patients require long-term oral anticoagulation, for example, for atrial fibrillation, and they undergo stent placement, they will require a short period of triple antithrombotic therapy with 2 antiplatelet agents and an anticoagulant. What should be our choice of agents? For the anticoagulants, we now have 4 randomized double-blind trials, actually 4 randomized trials that have established that direct oral anticoagulation is superior to warfarin and vitamin K antagonists in reducing bleeding without loss of efficacy. And therefore, I think we should definitely use, whenever possible, when renal function allows and there's no contraindication, we should try to use a direct oral anticoagulant. And if we have a choice of dose, for example, with the Bigatran, if you use the lower dose of 110 BID, you get lower bleeding further than with 150. And I think it's generally a good idea to use the safest dose of the safest anticoagulant in this setting. The second question is, what do we do with antiplatelet therapy? We are going to need dual antiplatelet therapy at the time of the procedure, but then maybe we can stop one of the 2 agents soon. And again, we have several trials that have established that it might be preferable to drop the aspirin rather than drop the P2Y12 agent, and that we can drop the aspirin fairly quickly after the procedure, as early as a week, and certainly as early as a month post-procedure. So that's number 2. The third question is, which P2Y12 inhibitor should we use? Clopidogrel, prasugrel, or ticagrelor? Again, I think our first and foremost concern in this setting is to reduce bleeding. And clearly, both prasugrel and ticagrelor will increase bleeding compared to clopidogrel. So my choice when I have to put a stent in a patient who's on chronic oral anticoagulation is to use the lowest possible dose of a direct oral anticoagulant to stop the aspirin as early as a week after the procedure, and to use clopidogrel rather than ticagrelor or prasugrel. And that strategy of short triple therapy, low dose DOAC, and dropping aspirin and using clopidogrel results in the lowest risk of bleeding. And as we've seen, when you reduce bleeding and you maintain the efficacy, you actually may even improve the efficacy because there is less cessation of antithrombotic therapy related to major bleeding. And we know that stopping major therapy, antithrombotic therapy because of major bleeding is often leading to catastrophic thrombotic complications. So this is what guidelines generally recommend, and this is what we do. Triple therapy for a week, stop the aspirin, use clopidogrel, and use the lowest dose of a direct oral anticoagulant. A second thing that I should have mentioned, and I didn't discuss it, is there is a simple thing that we can all do to minimize bleeding when we are using dual antiplatelet therapy or triple antithrombotic therapy. It's to add a proton pump inhibitor.
Yes.
We know that the first source of major bleeding is GI bleeding. Right. Approximately 40% of major bleeding in patients receiving antithrombotics is GI. And we have 2 randomized trials that have established that adding a PPI to antiplatelet therapy will reduce bleeding. And therefore, I think that it should be routine for the duration of combined antithrombotic therapy to systematically add a PPI to dual antiplatelet therapy or anticoagulant therapy plus antiplatelet therapy.
Thank you.
Thank you. Yeah, I think if we read in the Q&A, there are several questions which may be very interesting to discuss, because you mentioned the ischemic risk score and the bleeding risk score in ACS or in PCI patient. And until now, actually, there's not enough secure score which can be used to decide. And there's some issue of the, for example, Asian or East Asia population has high bleeding risk compared to, let's say, Caucasian. Do you think it's already clear about that issue that we have to reduce this because of the race issue?
So, so number one, I'm very aware of this, and I think the observational data points out to higher bleeding rates in East Asians. There's no discussion about that. Number two, I think that this means that whenever we treat East Asian patients, we need to be super cautious in terms of bleeding risk and use lower doses, lower potency of agents in order to minimize bleeding. Again, I think that Twilight and the similar studies have completely upended the field. I think that now this is a revolution in our thinking because we no longer need to have dual antiplatelet therapy. We can use monotherapy. And if we are in Asia, we certainly want to use monotherapy with 60 milligrams ticagrelor rather than 90 milligrams in order to minimize bleeding. So I think that this completely changes our thinking. But I want to point out that as I briefly said during the discussion, I think that we are not done yet with risk scores. I think we need further studies. We will, I'm confident that we will come up with the ultimate risk score in a few months or years. We are not there yet. We are still in the early stages of trying to do precision medicine and allocate the best treatment to everybody. It's very possible that in the future, risk scores will incorporate ethnic information or genetic information to tailor ischemic risk and bleeding risks to therapy. And therefore, or rather to tailor therapy to the ischemic and bleeding risks. So maybe in the future, we will use chips to look at polygenic risk score and say, well, this patient needs a potent therapy, this patient needs a less potent therapy, and this patient needs a long treatment, and this one needs a short treatment. Now, one of the questions that has come up is, should we do platelet function tests to guide the intensity of therapy? This is complicated. The first answer is, it makes a lot of sense because when we do platelet function tests, we see quite a range of response. We see patients who have excellent response to antiplatelet agents and patients who have little response to antiplatelet agents, particularly with clopidogrel. It's less the case with ticagrelor or prasugrel, but with clopidogrel, if we're going to use clopidogrel, it makes a lot of sense. The problem is there have been trials that have tested this prospectively, such as Arctic and similar trials. And as you know, they have failed. Gravitas has failed, Arctic has failed, Adaptes has failed. So we've had several attempts to compare trials, intensity of antiplatelet therapy guided by platelet function tests, which seems like a logical approach to conventional approach, and the conventional approach has won. And again, I think that maybe the monotherapy with ticagrelor strategy that was used in Twilight might solve the problem, because then we have a treatment that works always. We don't need to test everybody. It's consistent. It's monotherapy, so we don't have to worry about bleeding. The only issue that I see is cost, because I'm aware that ticagrelor is not generic yet in many areas of the world.
It will be.
But in a couple of years, it will be. So I think that, I think the problem will be solved when it becomes generic. It will largely be solved because then we will have a therapy that doesn't need to be tested, that works in everybody, and we can use monotherapy.
I think there's one question there or statement. Is there, or we have data that aspirin in diabetic patient also prevent event?
Ah, that's a very good question. I love this issue. We've done many.
The Themis use the placebo, not aspirin.
Well, Themis used ticagrelor versus placebo in addition to aspirin. So everybody received aspirin. Now, it's funny that you should ask, because when we designed the trial with Deepak Bhatt, we had planned to leave it to the investigators whether they wanted to use aspirin or not. Because as you know, the evidence that aspirin works in primary prevention in diabetics is not there.
Yeah.
There's actually a lot of debate. The previous trials had not clearly shown benefit of aspirin. The ASCEND trial suggested a modest benefit of aspirin, which was offset by increased bleeding. And therefore, the guidelines on both sides of the Atlantic do not recommend routinely aspirin in all diabetic patients. But it's interesting that the FDA demanded, when we designed the trial, they demanded that everybody be put on aspirin. So we had to oblige, and therefore we mandated aspirin in everybody. But I agree with you that the evidence is not there. Now, one interesting twist to the aspirin story in diabetes is that the diabetics have accelerated platelet turnover. And it might very well be that if you give aspirin once a day in diabetics, you are not covering the 24-hour cycle, because aspirin residence in the plasma is very short. And even though the effect of aspirin on platelets is irreversible, the aspirin will only inhibit the platelets that were circulating at the time of intake. Say for example, if you take aspirin in the morning, you will inhibit all the platelets that are circulating in the morning. But because diabetics have accelerated platelet turnover, they will have the bone marrow producing new platelets in the evening or in the night, and these platelets will not be inhibited. And there's actually pharmacodynamic and pharmacokinetic data suggesting that twice-a-day aspirin might be superior to once-a-day aspirin. Now, we are conducting with French colleagues a large-scale outcome trial called ANDAMAN, that's led by my friend and colleague, Dr. Dillinger. And that trial is randomizing diabetic patients to once-a-day versus twice-a-day low-dose aspirin. And we're aiming to enroll 3,500 patients and to see whether there's a benefit to twice-a-day aspirin. It's possible, it's plausible that twice-a-day aspirin might be superior to once-a-day aspirin if you have diabetes.
Thank you. Dr.
Okay,
Bambang?
Yep. Okay, thank you. Prospect, regarding the issue of giving PPI for patients who need triple antithrombotic therapy, we know that concerning the drug-drug interaction, we know that the dabigatran, the absorption of dabigatran may be reduced by if we combine with the PPI. Do you have any comment regarding that issue?
Yes, the comment I have is that we published yesterday. Yesterday, we published an analysis from Regional PCI looking at the PPI issue and the interaction. It came out in Drugs. It's led by Dr. Nicolau from Brazil. And this analysis that came out yesterday shows that there is no interaction, no clinically relevant interaction. So even though there is an in vitro interaction and a pharmacological interaction, clinically there was no difference, and there was a consistent benefit of the strategy using low-dose dabigatran and clopidogrel in these patients. So I think it's not relevant clinically.
I see. Thank you very much. So another question, Prospect. So if we have, let's say, the data from the platelet reactivity that there is, clopidogrel resistance. So
yes.
Can we change with ticagrelor, let's say, low-dose ticagrelor 60 milligram in such situation?
Yes, I'm always worried with clopidogrel, particularly if I use monotherapy with a P2Y12 inhibitor. I'm worried with clopidogrel resistance, which is why I don't often use it. I tend to use low-dose ticagrelor monotherapy. But if you test the patient and you find him resistant, definitely you should switch that patient to either ticagrelor or prasugrel, because you can't leave a patient on monotherapy with resistance to clopidogrel. The problem with the platelet function test is we are not absolutely sure of what is the proper threshold to define resistance. There is debate on what is the threshold, what is the test to be used, which is the optimal amount of agonist that you should give. So this is still largely debated. But because of that, I tend to use ticagrelor rather than clopidogrel. I'm not a great fan of platelet function testing.
Thank you, Professor. I think there are two participants asking about the sex. Female that you mentioned have more high risk of bleeding in antiplatelet therapy in ASEA-STEMI. Can you clear it out, please?
Yeah, there's no question that females have a higher risk. They have a higher ischemic risk because they tend to be older than men when they have an ACS. When they
Lower body weight, maybe also, yeah.
And they have smaller caliber vessels, so they get smaller stents. And they also have a higher bleeding risk that's been consistently observed, largely related to lower body weight, possibly to other biological differences. So I tend to consider women as high bleeding risk patients. This is one feature of high bleeding risk, and it tends to make me even more cautious with the intensity and the duration of antithrombotic therapy.
One question also is the patient who had bleeding during treatment of double antiplatelet or ticagrelor, when do you think it is safe to resume the treatment and the dose?
Yeah, so that's a very difficult question. I think it's a very relevant and very difficult question. I think we should acknowledge that there is no one single clinical scenario, that it will depend on the type of bleeding. If bleeding is intracranial, I will not resume antithrombotic therapy until the neurosurgeons and the neurologists give me a green light, which can be weeks, if not months. If the bleeding is GI bleeding or minor bleeding, of course, I may resume very quickly. However, I think that we should never take bleeding lightly, and that if we experience bleeding, we should ask ourselves, can I diminish the intensity and or the duration of antithrombotic therapy? Because if the patient has bled already, the risk of recurrent bleeding is extremely high. So for instance, if a patient is on ticagrelor plus aspirin and has a bleeding event, and I need to resume DAPT in the next few days or weeks, I will resume clopidogrel and aspirin, or maybe clopidogrel alone rather than DAPT, in order to try to minimize subsequent risks of bleeding. Regarding the timing of reinitiation, I think it really has to be related to the severity of the initial bleeding episode. If it's a minor bleed, I will resume very quickly, but I also will resume quicker if this is closer to the PCI implantation. If I'm 1 week post-stenting, I will not wait to resume. If I'm 6 months post-stenting, maybe I will not resume at all because I will consider that I'm done and I'll just stay with low-dose aspirin or maybe even nothing. So there are 3 factors. What is the intensity of bleeding? What is the risk of the patient? And what is the timing elapsed since the stent was placed?
Thank you. As one also good question here to discuss is the short-term 1 month, 3 month, 12 month of double antiplatelet or ticagrelor. Do you think it's related to the use of stent material or drugs eluting or polymer, which actually now are currently some sort of ad for the stent makers, that our stent you can safely use for 1 month, our stent we can use for 3 months.
So there is no question that the newer generation stents have a much lower risk of stent thrombosis than what we used even 5 or 10 years ago.
Yeah.
So I think that the progress we have made with stent materials and stent design have lowered the risk of stent thrombosis. However, as we saw already 10 years ago, stent thrombosis is only a small fraction of the ischemic events and the ischemic risk that patients are facing. After an ACS, more than 85% of the events that patients experience are not related to the stent. They are related to other plaques, other vascular beds. They might have a stroke related to a carotid plaque. They might have an arrhythmia. And so I don't think we should focus our thinking solely on the stent. The stent, we are treating patients, we are not treating stents. I want to really emphasize this again. And we should think in terms of the long-term risk of the patient. This is particularly true for example, when I see what I call the frequent flyers. When you get older as a PCI interventionalist, you see patients coming back time and again, you know, hello, Mr. Smith, you had a stent with me 5 years ago and now you need another stent, you have a new ACS and you haven't stopped smoking and you continue to be diabetic. And so you know that these patients, you treat them, but they might come back. And in these patients, I will tend to have an approach that is targeted to reducing their long-term risk rather than treating the stent that I just placed.
There's one question on how safe we give ticagrelor for, let's say, a very long time. Is there some sort of data that other than maybe cardiovascular, oncology, or something related to this until now?
So the data we have, most of the data we have for very long-term use comes from Pegasus. So it's up to 3 to 5 years. So it's not very long and not that many patients. As you know, there were questions that were raised regarding GI cancer and antiplatelet agents. There's been 2 large-scale meta-analyses that were done of randomized trial data on P2Y12 inhibitors, and they have been consistently reassuring. There is no signal that neither prasugrel, nor ticagrelor, nor clopidogrel increase the risk of GI bleeding. What happens is that if you give potent P2Y12 inhibitor and there is already a cancer, your chance of detecting it in the first few weeks or months is increased because this is like a bleeding stress test. And so, in fact, there might be earlier diagnosis and improved outcomes of patients with GI cancer if they receive DAPT because it's diagnosed earlier. But it's a difference in ascertainment rather than an increase in the risk of cancer. So I would say that so far, the safety data appears to be reassuring, but of course, we don't have a lot of data about patients receiving 5 or 10 years of ticagrelor, prasugrel, or clopidogrel. We don't, well, clopidogrel we do, but dual antiplatelet therapy with ticagrelor or prasugrel, we don't.
Okay, there's one good question now during era pandemic, especially because COVID pathophysiology can alter coagulation cascade. Do you think, is there any special adaptation or special, especially in anticoagulant and anticoagulant and antiplatelet therapy in this, yes, let's say, COVID and ACS?
That is an excellent question. There is absolutely clear, crystal clear data to show that patients with COVID are at very increased risk of thrombosis, arterial thrombosis, venous thrombosis, microvascular thrombosis, and probably stent thrombosis. And therefore, this must lead to 2 things. Number 1, we should definitely use prophylactic doses of anticoagulation in all COVID patients. And we might want to use slightly higher than usual or the higher end of the range of doses in these patients because they appear to have some resistance to anticoagulation. Number 2, if I'm using antiplatelet therapy in COVID patients, and presumably this is going to be because of an ACS, since we don't do elective procedures during the COVID, I will tend to use potent antiplatelet agents. So that will be one more incentive to use ticagrelor or prasugrel and definitely not use clopidogrel in patients.
Not clopidogrel.
They are a very high thrombotic risk. And we have seen stent thrombosis in COVID patients that receive clopidogrel. And I think it's advisable to avoid clopidogrel in these patients.
Thank you. Well, there's one question on clopidogrel resistance, but I think you are not pro of clopidogrel. If a patient can afford to have ticagrelor, why not ticagrelor? Dr. Bambang, is there any other issue regarding antiplatelets?
No, thank you.
Dr. Doni, do you want to ask a special question, especially on the cath lab double antiplatelet during COVID?
No. I think the one question for Professor Stack regarding the elderly population right now, because we now in Indonesia we tend to have a more and more elderly population. So what do you think is a special issue? Do you push ticagrelor for elderly patient for the long time?
Another excellent question. So I think it all depends on what you call elderly. In many trials, we used to define elderly as above 60 years of age or 65 years of age. And this was elderly 20 years ago. I think today, to be 60 is pretty young. Myself, I am 61. I feel very, very young. I don't call myself elderly. and I will not reduce the intensity of my antiplatelet therapy. And the data we have, for instance, in Plato, with respect to how consistent is the benefit and the safety in patients above 60 years of age and below 60 years of age, shows that at least in the 60 to 70-year-old range, there is no problem. The benefits and safety are consistent with the overall trial. The question arises when you get above 75 and above 80. And I think it's a fair question because we know that bleeding and ischemic risks increase exponentially with age. And to be fair, I think we don't have definitive data because in Plato or even in Pegasus, there were not that many patients that were above 80 years of age. So it's sort of a data-free zone. That doesn't mean that the ischemic benefits will not offset the bleeding risk, but it's because we know that ischemic risk also increases in the very elderly. It just means that we need to accrue more data. And I'm aware of analyses that from large-scale observational databases in Scandinavia that suggest that maybe we should do specific trials in the elderly above 80 years of age to explore what is the optimal antiplatelet therapy in these patients. We used to have very few such patients years ago, but today it's become an everyday issue. It's no longer the rarity. Now it's become quite common to have patients above 80 years of age. And the reality is that this is largely a data-free zone. So I think we should be cautious. We should generally be cautious in the very elderly patients.
Thank you very much, Professor Steck, for a very excellent presentation, nice discussion. And listen to your presentation, we all remember Paris. And we will come back to Paris for the next meeting, especially Euro-PCR, and maybe some of us will visit the North Paris hospital. It's your hospital.
You're welcome.
So if I have to wrap up, the most important message from Professor Steck for our meeting is first to consider monotherapy, especially if you want to use long-term antiplatelets, because there's already significant data, THEMIS, Twilight, that long-term monotherapy, especially with ticagrelor, it's effective and safe. The second, of course, we have to consider individual patient based on the comorbid risk score to choose double antiplatelet or monotherapy antiplatelet or triple antiplatelet, depend on the comorbid and the patient presentation. So again, thank you very much. And again, I hope you can have another time to discuss online distant learning with us. Thank you very much. And for AstraZeneca, again, I would like to thank for this opportunity. Thank you. The next, I think this is our program for the next presentation, and Professor Steck already left, so I can speak in Indonesian. The next, and I think we will have 2 Saturday meeting. First is next Saturday, July. This is very important topic, is performing high quality cardiovascular procedure, the importance of RCT and meta-analysis. And July 18 is percutaneous transvenous mitral commisturotomy step by step. Okay, wassalamualaikum warahmatullahi wabarakatuh. See you next time. Bye-bye. Saya kira sebelum berpisah, saya ditugaskan oleh Dr. Arwin untuk membacakan apa ini, menangkap ikan pakai jala. Ikannya lompat sampai ke mata. Pasti akan banyak kendala dalam meraih cita-cita. Lain kali menangkap ikan pakai pancing. Lebih memuaskan. Terima kasih.